imatinib is off patent.
Yeah.
Presumably it's getting cheaper. Presumably.
It should be.
It should be.
There's a funny deal going on, but
Yeah.
it's got cheaper for CML, but not for GIST. I'm not sure why.
Well,
it's all a
be
bit
that
dodgy.
as it may,
Yeah.
presumably it will get cheaper.
It will get cheaper, yeah.
Is there any chance of the double dose being more available, especially for exon 9 mutations?
I think that's a good point. I think if it becomes cheaper, I mean, it's much cheaper. The generic version is a tenth of the price or something. So if we can negotiate our way through that, then it should be much easier, because it will no longer become a big issue, because compared to other drugs, it will become quite cheap. These immunotherapies are, 3,000 or 4,000 a month. So, we're having to treat and that's in non-rare tumours, lung cancer. Potentially we may give it to all the lung cancer patients. And not only is that, you have to get them in every 3 weeks for treatment and deal with the side effects. So, that's why oncologists and oncology departments are all quite scared about it, because we think, how are we going to cope?
And what about nilotinib? Is that off patent as well?
I don't think so. That's a much more recently developed, so I don't know about the patent situation.
Because I know the evidence was a bit flaky, but we know of patients who did very well on it.
Yeah.
And it seems a shame that it's not available, just in case it does work.
That's right. Well, I think, that is frustrating in oncology that we have, like in general sarcoma, there's a drug called pazopanib, which used to be on the Cancer Drug Fund, came off. And the trouble is, because it's been priced for kidney cancer, which is slightly more common, the drug company can't do a special deal for sarcoma patients, and that happens with drugs. So we've got this funny situation where you can now get cheap imatinib for CML, not for GIST. I mean, it is farcical. And it's very frustrating. But we're as frustrated as you are, and we're sort of we're constantly lobbying and and showing our frustration. The NHS wasting money basically.
Sorry, I've got one more question. You're talking about combinations of drugs, say a few weeks on imatinib, a few weeks on sunitinib.
Yeah.
How do you get that funded when you've got competitive pharma companies both involved?
Well, that's another good question. That's the trouble with all this research. Like immune therapies, all the companies are now producing their own, and they're all copying each other and doing other drugs. But the trouble is, you often think, well, the combination of that one and that one would be great, but we can't get the trial done because you have to get Pfizer to work with Roche, so it is frustrating, and that's a problem, and that's why we need academic, university-based research, not just drug company research. But some companies will do deals, but there's a lot of strategy involved. With the immunotherapies, we've seen one company will bring something to market, another company will make it available on a compassionate use program, which will sort of block trials. So it's all a bit strategic. So I'm afraid it's, a lot of what drug companies is great. There's brilliant research going on. They're very supportive of research and can support things like this and patient support groups. But there's also a lot of hard-nosed business which can get in the way of research. Yeah.
Any other questions?
Had you sort of heard a lot of that before, or was it? Yeah.
There's a few.
We've got a few experts around, I'm sure.
Yeah, but also a few new people. So,
yeah.
I think the way you put that was, in the language that most people could understand. Hopefully,
yeah.
We've as you know, recorded you, so that'll be pinged off to other meetings that we have if you don't mind.
It's complicated enough for us, but we go to meetings and you hear this stuff again and again, and you see the immunotherapy data. And it was interesting for me producing this talk to go back and look at, do I really understand how that fits in and where we're going with this? And
just think, if you have continued with your immunotherapy treatment, we might have invited you sooner.
Well, exactly. I know, it was we wanted to see, that was an illustration, the CTLA-4 antibody came out. I said, well, this would be brilliant. Use the vaccine and the CTLA-4 antibody, but that time it's a new drug company, hugely expensive, while vaccines we can make cheaply. So, and that's what's happening now. They're starting to combine vaccines with these drugs, and looking very exciting. But, it's a very good time to be an oncologist because there are lots of new things coming on.
I think the other refreshing or good thing about this is that we've already mentioned that imatinib was found accidentally to be useful in GIST. And although that still happens, I'm sure nowadays with drugs, there's a lot more scientific research, more technical scientific research that allows you and your colleagues and research colleagues to really find the answers to some of these things. And as you said, it's an exciting time.
We can design the drugs.
Yeah.
Also, I say to patients sometimes, particularly if you've got a chronic condition where people can be on a tablet for a few years, by the time they progress, another tablet might come along or another discovery. So we've got, we had a patient with lung cancer who was on, when I first started in Bristol, 2008, she was on one of the blocking tablets, and then we gave her some chemo and some radiotherapy and things, and then she needed another treatment, and this other drug came available in the phase 1 trial. So she went off to have that in a trial and had that for another 3 years. And it was almost like it came just in time for her. And this is happening now with some of the other drugs. Just as people are starting to progress, we get access to a new drug. So it's it's really exciting.
And of course, for something to remember for all of us is it's not the same for everybody. You described earlier one of your first slides was a resected gist, all margins clear, but very high mitotic count. You described me. I've now been 7 years free of disease. I was on 3.5 years of imatinib with some side effects, and I'm now beyond 7 years, and hopefully that'll continue.
Yeah.
And that's the sort of positive output and outlook that I've got, and hopefully other people in this room will have, in order to I strongly believe that this thing inside this skull is the biggest asset that we as human beings have got in order for us to be positive and give ourselves as much of a chance of survival from all of these diseases that are all around the world. And earlier on, when Keris was talking about placebo, she said that there are some people that were on a placebo that were feeling side effects. Now, to me, that might have been because they had some surgery that caused them, but it also might have been this, telling them, because they didn't know they were on placebo, but telling them in their brain that they've heard about these side effects, so they've got these side effects. It's incredible. There's been programs on telly about placebos and ordinary drugs and following people through, and a doctor giving a scheme of 4 weeks of drugs where he starts with the drugs you're on initially and then goes to placebo in the end, and they're feeling worse. It doesn't make any sense, and the opposite way around as well. And the brain is positive. So I guess what I'm trying to say is, be positive, remain positive, and you'll give yourself the best opportunity.
Yeah, I mean, I wouldn't. The only thing I would say is some people have down bits. There's no proof that if you feel a bit depressed, sometimes it makes you do any worse. So, but what I do see with some patients is there are patients who, even with patients with very poor prognosis, so with other advanced lung cancer or something, there are people who think, well, at the moment they're on chemo, they're quite well, they get out and do stuff, and they have a life, and they see their family and their friends, and they do things. And there are other people who spend, and its personality is, you can't control it necessarily, but who spend all their time worrying about their symptoms and their treatment and what's going to happen in the future, and actually don't therefore live for the moment, don't make the most of that time. And that's always very sad, because you think, well, you're doing well at the moment, try and make the most of it. And it's a difficult scenario, but I sort of, you look at some patients, they're just amazing. They just sort of get on with their lives, and they know they're in a difficult situation, and they know ultimately they're not going to be cured, but they just get on with it. And you feel that's something to aspire to, really. But on the other hand, when you have your bad days or you feel a bit depressed, there's no evidence that getting depressed and things will do worse. But if you can get out and do things and live a fairly normal life, it's going to be better for you and your family, really.
I guess what I'm saying is, you guys are the experts on finding these drugs. We can't do that. That's not what we do. So the only thing that we've got to our advantage is this.
It's your attitude's great, and living a healthy lifestyle, going out, doing exercise, trying to eat fairly healthily.
My wife went through breast cancer 2 years after I went through what I went through, and her oncologist said the same thing to her. We asked the question, does she need to take 6 months off work for her cycle of chemotherapy? And he said, no, absolutely not. He said, I'll say the same as I say to everybody, which is try and maintain going to work. If you are that ill, you feel that ill, which you might for a few days, then take those few days off work. But he said, what I do find is that despite saying this, some people still take 6 months off work and end up becoming depressed and all the rest of it. And okay, some people can't help that because their minds aren't of that way. But my wife, she did, out of a 3-week cycle, 1 week or 5 or 6 days she was off work. The rest of the time she went back to work. She didn't feel great, but it made her feel better to be at work. and she got through it, and she's fine now. So anyway, there was another question. Deborah.
So I just wanted to ask a question really about, you mentioned about genetic testing. Obviously with there being a vast array of different types of cancer which are now rather than done by site-specific but by biomarkers, how do you see genetic testing needing to develop over the years? So for example, you're looking at a GIST or whatever type of cancer, and instead of it going, okay, it's a GIST, it's lung, it's this type of biomarker, where are we on that journey and what do you think needs to happen?
Well, there's lots of work going on. First of all, Charlie Swanton in London is doing a lot of research with rebiopsying people. And what you find out is it's a bit depressing in some cases, because they say take a biopsy of someone with kidney cancer, and they take a biopsy from the kidney and from the lung metastasis, and it's all got different mutations in the two different things within the same patient. So first of all, there's the complexity of that, and his work is looking at, can we go back to the root of, so that it branches off the evolution of the cancer, can we get back to the start and block that bit, and that's more likely to work. But also biopsies are quite tricky. So sometimes somebody's got a little tumour in the lung or something, it's in the middle of the lung, it might be difficult to get to. So how else can we biopsy? So we're also doing circulating tumour cells and circulating DNA, and what that is a blood test. And so you can now do a blood test. Reputable places can do this, because there are some slightly dodgy places selling the fact they can do this. Take some blood, spin down the blood, get the tumour cells, even tiny amounts of tumour cells. Here in Cardiff, they do this with ctDNA, which is circulating tumour DNA. So they take a blood sample, they spin it down, they separate the DNA, and out of all the DNA that's in there, a lot of it's normal, there's a bit of tumour DNA, tiny, tiny amounts, it's unbelievably tiny. But they can detect that, and they can find mutations in that. So in lung cancer, we can now give this first-line drug. They have disease that starts growing and becoming resistant. We take a blood test. We send it actually here to Cardiff from Bristol. We get a result back saying, yes, that mutation has been detected. We can now use this next tablet. So I think circulating DNA is really very hot at the moment, as in an area of research. I think that will be the way, because doing invasive biopsies isn't particularly pleasant. And if you can just do some blood tests and say, well, that mutation's turned up, give them that tablet. What we're going to need as doctors is we're going to need a computer to plug in, right, this patient's got this mutation, that, and they're this age, and they've had that drug. Which two options can we have? Because it's getting so complicated, we can't remember it all.
I just recently went to a conference in America, and they were talking about that particular subject, and basically saying that obviously with the circulating DNA, potentially you're going to pick up new mutations before they would actually be evident on a scan. So that would potentially be a way of addressing an individual patient's need for a particular type of medication or action far in advance of actually recognising a tumour had specifically developed. I mean, that's where it's going, I think.
And for diagnosis even.
Yeah.
But I've seen a graph of the circulating tumour DNA with the mutation goes up, and then the CT scan only starts showing something then. So,
Any more questions for Adam? Okay, right.
Okay,
Thank you very much. Adam,